Just to introduce myself to start with, my name's Dimple. I'm the Head of Development and Engagement here at NHS Providers, and I'll be chairing this session today. You'll probably already know that we are the home of provider trusts, and our role is to support peer learning and engagement across the sector for trusts and foundation trusts, and to help you all learn from each other and collaborate, and hopefully help you drive up standards during these difficult times. Today's a slightly different webinar from what we usually do because we've actually got some really great guest speakers here from NHS England who will be talking about the National Cancer Plan for England. The aim of the session is to really tell you more about the plan, some of those headline points in the plan, which I'm sure you've all read. And also it's an opportunity for the team at NHS England to hear what colleagues across the executive leadership across the NHS would find most helpful in delivering on this plan and what help you guys might need from the centre. So we've got David, the Director of Strategy and Policy here from the cancer team at NHS England, and also Rob, the Director of Delivery. So without any further ado, I'll hand over to David and Rob from the NHS England Cancer Programme team. Thank you.
Thanks very much, Dimple. So I'm going to kick us off. My name's Rob Stones. I'm Director of Delivery for the Cancer Programme at NHS England. David, do you just want to say your hello up front as well for us?
Hi, I'm David. I'm the Director of Policy and Strategy at the NHS Cancer Programme. It's lovely to see you all.
Thanks, David. And we have apologies today from Mark Cubban, who is the National Director for Elective Cancer and Diagnostics at NHS England, in addition to wearing his day-to-day Chief Executive hat at Manchester FT. Mark's unable to join today, but hopefully David and I have got enough of the subject matter knowledge to be able to give you a good walkthrough on the plan that we published on the 4th of February. And then to hopefully facilitate an engaging conversation and hear your thoughts on what you like about the plan, what you don't like, any other areas that you think a conversation would be useful. A big thank you to Dimple and the team at NHS Providers for arranging this event. We're really grateful to have the way in to have that conversation with all of you out there in the service. And thank you to all of you for taking the time out on a busy Monday morning, no doubt, to be able to fit this in. So it'll be a double act from me and David. I'll start by just describing a little bit the journey we took to publication on the 4th of February. David will then go into a bit more detail on a bit of an overview for the plan. We're not going to assume you've read every page and really studied it from cover to cover. So we thought helpful to just bring out a few key headline themes for you, which might just prompt some thoughts and discussion as we go. This was a really important plan for us. It's been more than 10 years since we last had a standalone cancer plan for the NHS for England. There have been bits and pieces of policy that we've sort of landed through our existing mechanisms, but to have the standalone prominence of a plan really helps to put a focus on cancer and how we're going to sort of set a set of objectives for the next 10 years and everything that we need to do in order to get there. Also, I would say it's a really important plan for our ministers. Our ministerial team has lots of personal experience of living with and beyond cancer. Ashley Dalton, who has been the Minister of State that's led on this from the ministerial team, she's living with cancer now and has really strong ideas of what she wanted to be in there. So lots of that personalised sort of experience is reflected in how we've landed on the plan. Wes Streeting too, as probably most of you will know, is a cancer survivor. So again, a really important personal mission for him too. Joe, can I ask you to take us on a couple of slides? Yeah, next one. Just pause on that one. That's great. Thank you. As you would expect, the National Cancer Plan being the first condition-specific plan to follow off the back of the 10-year health plan that was published last summer, it takes those three big shifts and seeks to hardwire it into the plan itself. So we've very much framed significant amounts of content within the plan about how that will translate into reality for cancer. So we've just picked out some examples there around the analog to digital shift, which runs through the plan. Lots in there around how new technology can help to improve access, efficiency, drive productivity, and ultimately help us land on our outcomes. Quite a bit in there around prevention policy, accelerating the work on primary prevention and early diagnosis, and then hospital to community, which is probably, I would say, it's fair to say, one of the more formative areas of policy, but incredibly important as well. And cancer cuts right through from people living with either symptoms or asymptomatically in the general population, right through to having diagnosis, treatment, engaging in clinical trials, living in a sort of remission state, and living long, happy lives, and increasingly treating cancer as a long-term condition, which that hospital community shift will really help to support. So probably no surprise that we would sort of highlight the fact that we've really sought to reflect those three big shifts, as well as some of the big bets that are in the 10-year health plan, which is a bit of jargon I'm not hugely keen on, but things like where use of AI and robotic surgery, for example, can really help to drive the latest cutting edge treatments and pathways. Joe, would you go to the next slide, please? This next slide just gives a little bit of a sense of how we built the plan. So really important call for evidence was run publicly last year. It was about a year ago that was first launched. Over 11,000 responses to that, so a huge task, and thank goodness for AI and its capability of being able to summarize and help us to prioritize the themes and areas to look for within that huge range of responses. Huge proportion of that came from people living with or who've experienced cancer, quite a significant component from people who care for people with cancer, and then all the big organizations out there played a really important part in shaping this. We nationally arranged ourselves around some expert reference groups. We had really strong involvement from clinicians, charities, royal colleges and industry. And those tight partnerships really helped us to shape something that I think landed pretty well a couple of weeks ago. Go on to the next slide, please, Joe. David will go into a bit more about the how, the plan and what it says and how it will seeks to deliver. But these are the three guiding core objectives, really. First one on access and how we will be able to restore delivery of the cancer waiting time standards by the end of this Parliament, which means 2029. The second is an extremely stretching, I would say, but with the right ambition, seeking to improve 5-year cancer survival rates to 75% by 2035, which would, I think, if we were able to deliver or get close to that, would genuinely give us a cause to say we are world leading. And then the third is around improving quality of life for people being diagnosed with, treated, or living with cancer. So those are the real three guiding ambitions for us. Final slide from me is the next one. And this just gives you the really broad overview of the plan itself. It has 6 main chapters. They cover what you see on screen here. David will unpack those as we go. The other bit I would say is running through the plan. We also have some cross-cutting themes on things like health inequalities and how digital transformation will help to underpin delivery of those objectives. So look, that gives you the sort of broad context and flavour. David, can I pass to you to take us through each of those 6 areas in a little bit more detail? Thanks.
Sure, thanks, Rob. Joe, if you move on to the next slide, please. And the next one. So I've totted it up, and I think there are around 125 commitments across the plan as a whole, which is probably too many. I'm pleased to say that not all of them are for us as an NHS. It goes much wider than what we do. What I can't hope to do in the time available today is to take you through all of those commitments. So what I thought I'd do is give you a flavour of the themes of some of these main chapters in the plan. So the first essentially repeats the commitment that was made in the medium-term planning framework back in the autumn to meet the cancer waiting time standards in this Parliament, which will build on the great progress that you colleagues around the country have made in turning round cancer performance over the last couple of years. The ways in which we'll do it are principally through continued expansion of diagnostic capacity. We'll continue to invest in community diagnostic centres across the country, ensuring that they are operating for longer hours and operating in a productive way. There'll be a continued push on streamlining cancer pathways, building on the excellent work that's already been done to get the front end of those pathways right, so that we're prioritising the people at most risk for diagnostic tests. There'll be an increased emphasis on straight to test pathways, and we're also working with the Royal College of radiologists to look at how we can streamline MDT working and improve the efficiency of that way. Underpinning all of this will be increased digitisation and using AI to really support the productivity agenda, and that will be really at every stage of the cancer pathway. We are getting, cancer will be a priority as the NHS app gets expanded. Patients will be able to book screening, all their screening appointments through the NHS app, I think by 2027. And we'll also continue to see the digitisation of histopathology services, which will improve turnaround times there, and the increasing use of AI to support imaging and radiotherapy contouring. Joe, if you put up the next slide, please. In terms of the core aim of the plan in many ways is to reduce the life lost to cancer, and there are three main ways in which we can do that, and those are covered in this chapter of the plan on improving cancer outcomes. The three things, there'll be a real drive on early diagnosis, building on the really impressive progress that's been made over the last couple of years, where we've seen the first increase in early diagnosis in over a decade. We're now 3.5 percentage points above where we were before the pandemic, which equates to about 10,000 more people in the past year being diagnosed at stage 1 or 2 as opposed to stage 3 or 4. I think targeting will be a big targeting people at most risk will be a big way in which we do that. We will. The plan commits us to completing the rollout of lung cancer screening across the country, which is transforming the early diagnosis of lung cancer. But we'll also see increasing efforts to target people who may be at greater risk of cancer for hereditary reasons, or through lifestyle factors. I think there will be a bigger emphasis moving forwards, and then we've perhaps had over the last couple of years in terms of improving the consistency of access to treatment across the country. At the heart of this will be a new set of cancer manuals, which establish a new set of quality standards for cancer against which providers, commissioners can benchmark your services. And the government, in terms of prevention, many of the levers actually sit outside of the NHS and with government in areas like alcohol labelling and smoking cessation. But it will be important that we continue to play our part as an NHS where we can, for example, in maximising the take-up of HPV vaccination and the cervical screening programme, which is an important way in which we are preventing not just cervical cancer, but about half a dozen other rare and less common cancers. Joe, next slide, please. There is the plan very consciously picks up on the hospital to neighbourhood switch that featured so prominently in the 10-year health plan. And I think for cancer, this is a major opportunity to improve and systematise the out of hospital support that so many cancer patients rely on. And I think over time we will see the development of a new support offer to cancer patients, covering every aspect of their cancer journey, through prehabilitation through to support for rehabilitation after treatment, and then continuing support for people living with cancer as a long-term condition. And I think digital monitoring, digital support will continue to play a really important part in that. And and the basic philosophy here is the same as the philosophy for why neighbourhood services will be so important for people living with other long-term conditions. Essentially, what we want is to see people living well with cancer and supporting them so that we prevent them getting to a crisis point where they end up in A&E or with an extended stay in hospital. I think a really new and important focus of the plan will be in terms of the support that we provide to people to enable them to stay in work once they've been diagnosed and treated with cancer. We know that many cancer patients just want to get back to the life that they had before cancer, and being able to stay in employment is an important part of that. Underpinning all of this will be partnership with cancer charities and others who will be partners in neighbourhood services moving forwards. I'll continue to rattle through. If you could go to the next slide, Joe, please. The plan also seeks to we're blessed in the UK with a world-class life sciences sector and research sector, and the plan really seeks to mobilise that research community to support the priorities set out in the plan for cancer. The plan sets some very clear national research priorities, which will be reviewed every 3 years, and sets out a series of commitments to help accelerate the establishment or startup of clinical trials and improve access to them across the country. All of this will be underpinned by an expansion in genomic testing, ensuring that many more cancer patients get access to genomic testing within a clinically meaningful timeframe. If you move on to the next slide, Joe, please. The government established a Children and Young People's Cancer Task Force, which was a cross-party task force co-chaired by clinicians and experts in children and young people's cancer, and it came up with a series of recommendations which form the basis of this chapter of the plan. The main aims of the commitments set out there are to improve collaboration between primary and secondary care in terms of the early detection and diagnosis of childhood cancers. There are commitments to improving access to genomic testing for children with cancers, and finally there's a set of proposals around wider support for children and young people with cancer, probably the centrepiece of which from the government's perspective is a new travel fund of up to £10 million a year to support children and their families with the costs of repeated travel to principal treatment centres across the country. If you can move on to the next slide, please, Joe. There's also a significant emphasis in the plan on rarer and less common cancers. I think there's a sort of moral imperative we have to improve outcomes for people with rarer and less common cancers, but there's actually also a mathematical imperative here. Rob at the start set out the ambition in the plan to get to 75% 5-year survival by 2035. We're simply not going to get anywhere near there if we don't make progress in some of the in terms of survival in some of the rarer and less common cancers cancers where survival rates have been stubbornly low for many years. There's a big political push behind this as well. There's a rarer cancers bill currently going through Parliament, which ministers are committed to implement, assuming Parliament passes it. Some of the priorities here include developing more proactive approaches to case finding for some rarer and less common cancers, building on the approaches that we're already trialling on pancreatic cancer and hepatocellular carcinoma. The plan makes it clear that rarer cancers should be a priority for research and clinical trials, and there's a specific announcement about more investment going into research into brain tumours in particular. And we're also committing to increase the granularity of the data that we publish on rarer cancers, both from both in terms of survival and mortality, etc., and also in terms of cancer waiting times data. Next slide, please, Joe. Health inequalities, as you would expect, is a significant theme that runs through the plan as a whole. There's a particular focus for us as an NHS cancer programme on reducing the gap in early diagnosis between the richest and poorest areas of the country. We inherited a few years ago an 8 percentage point gap in early diagnosis, and I'm pleased to say that largely through the lung cancer screening programme, we've closed that 8 percentage point gap by a quarter over the last couple of years. So it was 8%, it's now around 6%. But we need to do more, and there will be a big focus moving forwards in terms of targeting the areas of the country and groups within our communities amongst whom we know rates of early diagnosis are lower. There'll be a big push to ensure that services are more accessible to more people. If you think about screening, for instance, there'll be a continued push to make home sampling available in the cervical screening programme, ensuring that mammography machines are accessible to people with physical disabilities. All of that will continue. And finally, I think importantly, given the significant emphasis on the role of digitisation, the NHS app, etc., in terms of the delivery of cancer services and NHS services more widely. There's a clear commitment to creating a level playing field. We're using that new technology to create more of a level playing field in terms of health literacy and patient empowerment. So I just wanted to finish that. Those are the slides which I've rattled through, and you can see some of the specific commitments that are included in the plan in the slides. I just wanted to reflect for just a moment before we go to questions about what this will mean in terms of differences in how we work. And I've come up with 5 Ps, which makes me slightly worried that I'm giving you a distorted version of what's in the plan, because I was sort of, it didn't begin with P. I've sort of like not included it here. But let's go with it. So the first is around partnership. I touched on this already. There is a significant emphasis on the importance of partnership working running right through the plan, and I think this partly reflects where we are, in financial terms as an NHS. We can't and shouldn't expect to do all of this on our own, and particularly as we see more psychosocial support services delivered through neighbourhood settings, it will be really important that we find new ways of working with and financing those partnerships with cancer charities and others. There'll be a significant emphasis, as you would expect, on productivity in the plan. Taking advantage of digitisation, advances in AI to improve the way in which we work, but also I touched on things like MDT working. I think there are just good old-fashioned effective management can help hugely in terms of driving improvements in productivity. You'll see a continued drive towards the personalisation of cancer services, partly driven by genomics, and over time the plan suggests that we will move to a more predictive approach to cancer care. I don't think that's going to happen overnight, but that's certainly a direction of travel signalled by the plan. My fourth P is people. We will see some expansion in the size of the cancer workforce over the 10 years of the plan, but I think almost more importantly will be the investment that is signalled in terms of the development of the cancer workforce, creating new roles in the cancer workforce, creating 5,000 training opportunities a year, so that we can equip more people to work in different ways to support the cancer patients in our care. And then finally, patient power. This was a big theme in the 10-year health plan. I think you will continue to see a very big drive to use the NHS app to empower patients to be more in control of their cancer journey. You'll see a shift towards providing real-time feedback to clinicians and treatment teams through patient-reported outcome measures, which we hope in turn will both improve the experience of individual patients, but also the services that we provide more generally. And I'll stop there.
That's great. Thank you so much, David and Rob. That was some really interesting insights from you guys, having developed the plan. And you'll be pleased to know, I know that you've been busy in presentation mode, but we've actually got 3 pages worth of questions for you. So obviously a really engaged group. We've got 200 people on the call. So really great to have such interest in this very important topic. For anyone who joined a bit late, just again, apologies about the link issue. That's totally my fault. I pressed a button and caused chaos, so the team had to create a new link. So hopefully you've been able to join for the majority of this session. But just to confirm, we will be sending the slides, the recording, and a kind of summary of the Q&A document out to colleagues in the next kind of week or so. So you will still get everything there. So we will go to a kind of more formal Q&A, and please do put your hand up using the raise your hand button in just a second. I know in large meetings like this, people can feel shy, but please do this because it's, Rob and David really want to hear from you guys and in your voices as well. But whilst we wait for people to break that and actually open the questions, I'll ask just a couple that have come up in the chat. David, you talked about liking words with P, and I can't think of a question as such, but maybe these are pointed challenges for you guys to consider. So there's a few helpful comments in there as well, but I'll just pick a couple of questions which kind of really came out well for me. So you've talked about living well with cancer, and that's obviously a key part of this plan. Is the goal of 3 in 4 doing so measurable? How will you know you've achieved that, living well with cancer?
Shall I come in on that one, David, first? So I think that 3 in 4, I mean, that is very measurable, but that in and of itself does not answer the question of how are we assessing whether patients are living well with cancer. I think we will absolutely draw on a much wider range of intelligence to be able to do that. We already have a very good cancer patient experience survey, which gives us lots of useful metrics, and that will continue. There's no intention to stop that survey. I think the main complement to it will come from the PROMs and PREMs information that we want to develop. So that's patient-reported outcome measures and patient-reported experience measures. I think we've got a real opportunity here to better hear more directly from patients about their experience of care, and use more, in the same way as other industries would use that flow of customer information. Actually, I think we've got some really good opportunities here to better develop that flow. That would be my answer there. But the exact measures, I would say probably TBC, to be honest. There's further development still needed there.
Thanks, Rob. And presumably you'll be engaging with people on helping to define some of that as well. So actually this is an important point to raise. Actually, what's your views on that as well, members of the audience? Another question, actually, a few people have mentioned this, which is around the provision of psychological care for patients who are experiencing cancer. So there is a little bit in there in the children and young adults part of the plan. There's not much else anywhere else. I wondered if you would be able to comment on your thoughts around that.
Do you want me to go on this, Rob? I mean, I think this is an area where we've made really quite significant progress over the last 2 or 3 years. We've asked, as a national cancer team, we've asked cancer alliances to conduct the first audits of psychosocial support that's available in their areas, and cancer alliances have been working with their local systems and providers to address any gaps. It will be an absolutely central part of the broader support offer that we provide to cancer patients moving forwards. We know it's a really important point for cancer charities and for cancer patients themselves. And so if we've underplayed it in the plan, I apologise, but I just want to reassure Jenny and other colleagues that it's absolutely central to what we are seeking to deliver moving forwards.
Thank you. Helen, did you want to come in?
Thank you. Yes, I'm one of those psychologists, so I'm just picking up on that point. And I guess, having looked at the plan, I do feel it's a bit underplayed, if I'm completely honest, partly because for us, getting the traction to improve psychological services within trust is very difficult. So the alliances are showing that there are huge gaps, not really gaps so much as kind of aching cavities. It's really kind of awful seeing how bad it is, actually. I work in a big university teaching hospital, and we don't have psychology provision across the majority of cancer care. There's a reliance on third sector, which is absolutely important in the picture, but clearly misses huge amounts of what we need. And in particular, things like promoting patient self-management, promoting shared decision-making, those kinds of things. You need that psychological care within the MDT. And where psychological care is referenced under supportive oncology, you talk about liaising with radiologists, with physicians, but there's no mention of liaising with any of the psychological bodies. So I guess I would really encourage some thought into working together with ACP UK or BPS, so the Association of Clinical Psychologists UK or British Psychological Society, to really push this forward, because without the engagement from the psychologists, it's really hard to deliver that psychological care in an embedded and meaningful way within acute trusts to enable good neighbourhood care once people leave hospital. Because without that care in the acute trust, you find that people leave with all of the problems of having missed that step. Thank you.
Thanks, Helen. I think those are all excellent points and well made, and we will certainly, as I say, we are absolutely committed to improving the support that is provided to patients in this area, both at different levels. The more the psychologist-led support that happens in trust, but also I do think the work that the cancer charities and others do in this space is important too, in facilitating things like peer support groups and what have you, which I know many patients really value.
And David, I'd say an important point from Helen there as well around the MDT review. It's not just an RCR review of MDTs, it's RCR led, but I think we should make that point of feedback to the team that are currently scoping and working through that piece of work. So I think it's a really important consideration. So thank you for that.
Thanks, Helen, for that question. There's lots of comments in the document as well about the psychological support. I think we're all aware that it's not just about the kind of treatment part, but it is that kind of holistic care of the patient. So some really important points there, everyone. Thank you. I'll just move over to another question, and again, just encourage anyone to pop their hand up for other questions that they want to go to as well. So there's a question, well, there's actually quite a few questions and comments just around how the role of different organisations. So there's mention about where ICBs fit in, where they fit in regards to the cancer standards. Also, what about the Cancer Alliances? They've done a lot of work, particularly around screening. So where do they sit in this? There's also not much mention beyond the ODNs as well. So just wonder if you can maybe give us a flavour of who you see as supporting implementation of this plan and the different bodies who will have a role in some description. Thanks.
Shall I go first, David, and then you add any further thoughts? So, I mean, the first thing I would say is that the plan does commit to the Cancer Alliances as an enduring model for delivery for us, really important, and the progress they've been able to support and to drive to date is recognised and reinforced. So in terms of where they sit, they continue. We have commitments from government around continued sort of flat cash levels of service development funding, which will really help us to continue to drive the agenda and the priorities that are set out in the plan. We are, of course, working in a moving operating model for the NHS nationally. We ourselves in NHS England and across the department, we're in a major period of change and transition. ICBs, of course, are going through a very challenging period of change as well. So we're really conscious of that. And I think it will be really important for us to sort of keep the objectives of the plan in mind as the new organisations land and begin to settle. But there is a lot of uncertainty there, I think it's fair to say. But in terms of the ICB role, I mean, that is a sort of evolving relationship with the provider sector. And so, the model ICB, I suppose, sets the overall framework in which we need to work. I think the other key piece of sort of strategy and national design work that's happening is around the neighbourhood model. And I know, Dimple, there are questions in there around where that's going. I know nationally in NHS England, there's work around a framework for neighbourhood care, which is in development, but nothing sort of out there yet. David, you and I are working with the team that are leading on that piece of work to make sure the sort of considerations for cancer are considered and reflected accordingly. I think it's going to be quite a high level and broad framework. So, you know, it won't give many people on this call the specificity they might be looking for, but we are pushing hard to make sure that the use case for cancer is really strong and considered. And I think the plan gives us a good basis on which to represent our needs. But David, do come in with anything more sort of thoughtful on that.
I think you covered it well. I mean, ICBs will obviously continue to have, formal accountability for, delivering on the cancer waiting time standards. The plan commits to ensuring that cancer outcomes, including survival, early diagnosis, will be included in the outcomes framework for ICBs moving forwards. There is what I hope the plan does by giving certainty to the Cancer Alliances is, create a strong and united front locally with ICBs for taking forward the commitments in the plan. I've always thought that the relationship between ICBs and Cancer Alliances should be a mutually reinforcing one. So for ICBs, what you've got in the Cancer Alliances is cancer expertise, which is really important given how complex cancer is. You've got ring fence funding to drive improvements in cancer, and you've got boots on the ground, and so all of which should be a boon to local systems, and for Cancer Alliances in return acting with the authority of their local system, their ICB, will just lend greater weight to their work with providers and others across the local system to improve cancer outcomes.
Thank you both. A really comprehensive answer, and obviously a difficult one as well with so much change across the system. If anybody wanted to specifically come in on those points around the alliances, ODNs, ICBs and others. There was quite a few comments around that in our now 6 pages of questions and comments, and that will be great. Joe, did you want to go ahead?
Well, thanks for giving me the opportunity to raise a question. Personally, I hope it's appropriate to do so. So I'm a GP with roles both in a cancer alliance and an ICB, at least one of which is likely to evaporate in the hollowing out of ICBs. I suppose my concern is around how the move towards neighbourhoods and simultaneous move of ICBs into a much more strategic role risks the fragmentation of the bit of work that I've dedicated a significant part of my life to, which is the interface across primary and secondary care in the cancer pathway. So how do we make it clear and understandable for primary care practitioners and patients how to access diagnostic services for cancer? And in a world where ICBs no longer have the role or capacity for defining what a primary secondary care pathway looks like, in a health economy like Devon, where we've got multiple providers, single commissioner, and a much larger number of neighbourhoods evolving, how will we maintain consistency in that pathway? How do we ensure that somebody living in one small coastal town has the same sort of access to cancer diagnostic services as somebody living in a town maybe only a few miles down the coast, but served by a different acute provider? Because one of the things that ICBs has done, sorry, I'll stop talking in a minute, ICBs have done around this interface space is to ensure that providers have to adhere to a common set of standards at the interface, as opposed to just the monitored faster diagnosis standards, which don't really speak to the same thing. Thanks. I'm really sorry to waffle.
Good. There was a lot in there, Joe. I think you make some excellent points. I actually see big opportunities for cancer in the shift to neighbourhood, because I mean, I should say at the outset, at first it was almost the one of the 3 shifts that almost resonated least for cancer, at first look. But actually, if you think about it more deeply, I think there are real opportunities with the growth of neighbourhood services, which don't exist yet, and this will take time to develop, to systematise the out of hospital support that many cancer patients rely on, and ensure it is better integrated with the in-hospital support that that people receive. That the plan sets out a vision, and this will take a long time to achieve, whereby cancer patients should have a neighbourhood care coordinator who coordinates their access to all the out of hospital support services, and whether that's psychosocial support, employment support, monitoring for cancer coming back, all those sorts of things, and integrates that more effectively with the in-hospital support. So it's sort of getting that nexus between the two feels really important. And I think as a first step towards that, we are asking cancer alliances to work with local commissioners and nascent neighbourhood services around the country to develop models of care that exemplify what's possible in that space. In terms of how in a sort of more localised operating model we ensure equality of access to services, whether those are diagnostic services or treatment services, I think this is where the cancer manuals that I describe have a really important role to play. So the idea is that we will, this is a sort of going back to the future thing. Those of you who remember in the noughties, we didn't have, there was no national service framework for cancer as there was for other conditions. What there was a series of national cancer plans backed up by more detailed cancer manuals establishing quality standards for the delivery of different cancer pathways. And so I think it's by establishing clear quality standards for cancer, which will be something against which clinicians, trusts, commissioners can benchmark the service they provide, I think it will help ensure consistency of access across the country. It will also be quite a powerful tool in the hands of patients as well, who will be able to say, well, actually, this quality standard says I'm expected to get this, that, or the other. And if that's not the experiencing that they're getting, I hope it will enable them to challenge their local system, their provider, effectively.
Thank you so much. Definitely some robust challenge in there. So it's useful for you guys to hear that. If I just take us to inequalities now. So this has come up in quite a few areas, and obviously it's a central part of the cancer plan. So what kind of levers will systems have to genuinely reduce inequalities and cancer outcomes? And how might you go about addressing those disparities and maybe even incentivizing the reduction in inequalities?
Do you want me to go first, or do you?
Yeah, you go first.
Well, as I said a bit ago, actually, I think certainly when it comes to cancer, I think we have got a very strong track record in terms of addressing health inequalities. What is being achieved through lung cancer screening is quite extraordinary. Lung cancer on its own is responsible for about 1 year in the 9-year gap in life expectancy between the richest and poorest areas of the country, which is all wrapped up with rates of smoking, etc. In those areas, and through the way in which we targeted the lung cancer screening program, you're now more likely to be diagnosed with lung cancer at an early stage, with all the potential for curative treatment that goes with that. If you're living in one of the 20% most disadvantaged areas of the country, than if you're living in one of the wealthiest areas of the country. It has actually sort of transformed the health inequalities position on the early diagnosis of lung cancer. And I think we need to take our cue from that and take our cue from how we use data to target that program effectively, and ensure that we are using we're awash with data in cancer, which is a real blessing. And so we should, what we are asking Cancer Alliances very specifically to do is to use that data to identify the pockets, whether that's geographical or other pockets within their local populations amongst whom rates of early diagnosis are lower, and then work with those communities to target awareness messaging and encouraging people to, if they've got concerning symptoms, to come forward and get themselves checked. And if we can continue to do what we've achieved through lung cancer screening, I think we can make a real impact.
Thanks, David. And I was going to mention the data. I think the plan puts quite a strong emphasis on transparency and us making sure we have clarity and detail and can bring to light and shine a light on those areas where inequalities persist and where boards should be taking action locally to challenge that. I think, though, more important is having well-designed policy and having funding that actually supports delivery of reduction of health inequalities. And I genuinely don't think it has to be one or the other in terms of our overall goals and the objectives of the plan, or having health inequalities. I think that's a sort of false dichotomy, really. I think lung cancer screening is a great example of where we can improve early diagnosis by actually reducing the health inequalities gap and by targeting those populations at greatest need. For the screening programme, you do both, you achieve both. And so I think that's the mindset we have to have in all of this as we progress. But I can see there's a hand up in Dimple.
Thanks, Rob. I think really important points in there just before I bring in our colleague with their hand up. Alison, did you want to go ahead?
Yeah, thank you. It's been a great seminar and it's really exciting. I couldn't agree more with David around the neighbourhood and the difference we can make. I work in a cancer specialist hospital and we educate pre-registration nurses and AHPs around cancer. And I can say unequivocally that most of those learners join the platform with a real sense of cancer equals death today. That's where they're thinking in the general workforce. And I think unless we can start to recognise that cancer being socially constructed and the opportunities we have with our future workforce, the diversity, that every contact counts, and reaching their own communities, that's what's going to be really making a difference. So there's something around trauma-informed education around our nursing and AHP workforce, but bringing colleagues with us who won't necessarily specialise in cancer, but will be fundamental in those early contacts with their community. So I just wondered how we become more clear with HEI providers that cancer needs to be a core part of a nursing and AHP curriculum and the wider health and social care curriculums.
Alison, I think you make some really excellent points. I mean, I would love there to be more time devoted to cancer in core curricula. But equally, I'm acutely conscious that colleagues who are responsible for all sorts of other conditions will say exactly the same. I think, one of the things I think is really important as we go about our work in the NHS is just to continue to emphasise, that message of hope around cancer, about the improvements that are being made. If I look at if I look at some of the core data around the three principal objectives of the plan that Rob outlined earlier, on cancer waiting times, actually, we're still miles off where we want to be, but we are now meeting the faster diagnosis standard, meaning more than 3/4 of people are getting a definitive diagnosis or ruling out of cancer within 28 days. Over 90% of people are, beginning treatment within a month of a decision to treat. If you look at rates of rates of survival have never been higher. Rates of early diagnosis, as I said earlier, have never been higher. We're now 3.5 percentage points above where we were before the pandemic, and we're continuing to tick up at a percentage point a year. That's 10,000 people a year being diagnosed at stage 1 and 2, as opposed to stage 3 and 4, with with all the potential for curative treatment that goes with that. And then actually, I look at patient experience. I look at the job that you and colleagues around the country are doing and the feedback that you're getting from patients. And on average, 64,000 people completed the last cancer patient experience survey. So it's not a small sample. And on average, they rated their overall experience of care 8.94 out of 10, which is extraordinary. You compare that to rates of customer satisfaction in any other walk of life across the country, and people would be biting your hand off, frankly, for those levels of customer satisfaction. So there is a very positive story to tell about cancer, and I would encourage all of you to continue to tell that story, because it's actually your story. This is what you are delivering through your work with cancer patients day in, day out, and just want to say a huge thank you to all of you for that.
And David, I think an honest reflection from us in terms of how the plan came together and the end product that you all see there. One of the areas we were at pains to really try and push with the political team was around that positive narrative. Now, we didn't hugely win that battle, but it does make me a bit nervous, Alison, in terms of the general sense that you get from your colleagues at all levels and across those professional groups, that is still a sentiment that holds for them around the death sentence point, when in fact there's lots of evidence to the contrary there. So I guess my plea to everybody is to sort of see past a little bit some of the stronger messages up front in the plan, but really focus on where we genuinely think we can get to, and also the belief and the hope that we take from that really great progress that we have been seeing in recent years as well.
It's a young one.
Thanks all. We're almost out of time, so I'm just going to ask one more question, which is actually interrelated. It's come up quite a few times in our now 7 pages of questions for you guys to hopefully answer offline. So there used to be a plan for replacing equipment such as radiotherapy equipment, and that was funding was made available for that. We also know that there's a massive estates and capital issue across the NHS as a whole. So what can be done in that regard to help support the cancer ambitions? And then obviously a linked question to that is the workforce, because you can have all the things in the world, but what about the people? And we know that there are particular workforce shortages, not just with radiologists, but also a number of CNSs. We've talked about the psychosocial support for colleagues as well. So just wondered if you can touch just briefly on those points as well, please. Thanks.
So I think those are really important areas. In terms of capital and investment, what the plan didn't come with was major new investment. You know, I think everybody would recognise the really challenged financial context in which the plan's been written and landed. I think that goes into the broader shifts around future strategic commissioning and overall management of the capital budgets within the ICBs. Remind me what the other point was, because I focused on that one, Dimple. What was the second part of the?
It's capital and then linked to workforce as
well.
Oh,
workforce, yes. Sorry, thank you. And
one
then
of the most key ones, yes.
Well, I know, and some of the commentary I know out there was sort of slightly critical of the fact the plan didn't go deeper on workforce. I think that was a deliberate move because there is a separate 10-year workforce plan in development. We sort of wanted to set that up as much as we could through the plan at this stage. Again, I suppose the context on that is, there has been significant growth in the workforce. Is that question over whether that continued growth is financially sustainable? Actually, there are other ways that we will need to work with the future resource that the NHS has in order to deliver on the outcomes that we're seeking to deliver. Now, there will be pockets of challenge within that workforce, particularly for cancer, and that's where the modelling needs to bring that out. That's a work in progress. David, we're working with the workforce team nationally, aren't we? And more to come on that is probably what I would say.
Great, thank you. So I'm just conscious of time now. So we're just at time now. We've obviously had really great start of the conversation, and clearly with over 200 people joining this call, there is obviously lots of interest in this and wanting to also, it sounds like, to support NHS England in kind of those more granular details which will be coming forward. So just like to say thank you to both David and Rob for giving their time today, and to all of our attendees today.